Good morning. I'm Dr. Mahendran, and I am assistant professor in the Department of Respiratory Medicine, Santosh deemed to be University. Today, I'll be taking a lecture on pneumonia. Definition: pneumonia is an infection of the pulmonary parenchyma. Clinical symptoms of acute lower respiratory tract illness, which include cough with or without expectoration, shortness of breath, pleuritic chest pain. Patient will have new focal chest signs on examination and often have at least one systemic feature like fever, that is temperature more than 37.7 degrees Celsius, chills, rigor, or often severe malaise. Radiographic features will be new radiographic shadow which has no other explanation. Other explanations can be pulmonary edema, pulmonary infarction. The patient often present with lobar or patchy consolidation, and the X-ray often shows loss of normal diaphragmatic, cardiac, or mediastinal silhouette. Interstitial infiltrates are also often present in certain etiology. Proliferation of microbial pathogen at the alveolar level. Proliferation of microbial pathogen at the alveolar level and the host response to those pathogen occurs. Microorganisms gain access to lower respiratory tract in several ways. Example is inhalation of infectious particle. Example, COVID-19 virus. Second is aspiration of oropharyngeal or gastric contents. This is often present or happens in patients whose gag and cough reflexes are impaired, or during sleep, especially in elderly. Another mechanism is hematogenous spread, example endocarditis. Contagious extension can also happen, for example, infected pleural cavity or infected mediastinal space can lead to pneumonia. Then there is also the fifth type, that is called reactivation. Example is tuberculosis, and this reactivation is more common in immunocompromised host. Pneumonia historically was classified into community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. So, community-acquired is acute infection of pulmonary parenchyma in a patient who has acquired the infection in the community. Hospital-acquired pneumonia that occurs 48 hours or more after admission and did not appear to be incubating at the time of admission. VAP or ventilator associated pneumonia also develops more than 48 hours after endotracheal intubation. The mechanism is microaspiration. Bronchopneumonia is the most common pattern seen in nosocomial pneumonias of hospital-acquired and ventilator-associated pneumonias. Lobar pattern is more common in bacterial community-acquired pneumonia. So as you can see, the pictures representing that lobar pneumonia, the etiology is pneumococci, Klebsiella pneumoniae, Legionella. Bronchopneumonia is Mycoplasma, Chlamydia, Staph, and Pseudomonas. Interstitial pneumonia, viruses, PJP, fungus, Mycoplasma. Pathology of lobar pneumonia. There is four stages. That is edema or congestion, red hepatization, gray hepatization, and resolution. The edema or the congestion stage, there is presence of proteinaceous exudate and bacteria is often present in the alveoli. This phase is rarely evident in clinical or autopsy specimen because of the rapid transition to the next phase, that is the red hepatization phase. There is presence of erythrocyte in the cellular intraalveolar exudate. There is also neutrophil exudate, which is a part of host defense. Bacteria are occasionally seen. Next is a gray hepatization. Here, neutrophil is a predominant cell. There is no new erythrocytes extravasity, and those already present has been lysed and degraded. Fibrin deposition is abundant and bacteria has disappeared. Successful containment of infection and improvement in gas exchange. Then the fourth stage of resolution. Macrophage appears as the dominant cell type in the alveolar space. Debris of neutrophil, bacteria, and fibrin has been cleared, so has the inflammatory response. As you can see, the histological histology of the four stages. It is the initial phase, early consolidation, late consolidation, and resolution. Pathophysiology. The host inflammatory response, rather than the proliferation of microorganisms, trigger the clinical syndrome of pneumonia. Release of inflammatory mediators interleukin-1 and tumor necrosis factor results in fever. Cytokines such as interleukin-8, GCSF stimulate the release of neutrophil and their attraction to the lung, producing both peripheral leukocytosis and increased purulent secretions. Inflammatory mediators released by macrophages and the newly recruited neutrophils create an alveolar capillary leak, equivalent to seen in acute respiratory distress syndrome. Even erythrocytes can cross the alveolar capillary membrane, resulting in hemoptysis. Capillary leak results in radiographic infiltrates and crepitations or rales detectable on auscultation. And because of the alveolar filling, there is hypoxemia. Because of the increased respiratory drive and the increase in the respiratory rate, the patient may often present with respiratory alkalosis. Decreased compliance due to capillary leak, hypoxemia, increased respiratory drive, increased secretion, and infection-related bronchospasm leads to dyspnea. If severe enough, they change the lung mechanics and there is reduction in lung volume and compliance, and there is intrapulmonary shunting of blood causing respiratory failure and may even progress to death. So, as I said earlier, the four stages of pneumonia and their associated auscultatory finding. The stage of hyperemia or congestion, there is diminished vesicular breath sound with fine crepitations, which is called the index crepitation, present in 24 to 48 hours. The second stage is the stage of red hepatization, 2 to 4 days. Third is gray hepatization, 4 to 8 days. It presents all the classical features of consolidation. The fourth stage of resolution, the breath sound is vesicular or rarely bronchovesicular. We can also hear the coarse crepitation, which is called the redux crepitation, and this may persist up to second 2 to 3 weeks. Respiratory symptoms and signs in consolidation are often absent in elderly, alcoholic, immunocompromised, or neutropenic patients. So, this is the list of microbial cause of community-acquired pneumonia by the site of care. In outpatient, it is often the pneumococci, Mycoplasma pneumoniae, H. influenza, C. pneumoniae, and the respiratory viruses, which include influenza A, B, human metavirus, adenovirus, respiratory syncytial virus, parainfluenza virus. In the hospitalized patient, in non-ICU, it is again the same list, and in case of ICU, the organisms are pneumococci, Staph aureus, Legionella, gram-negative bacilli, H. influenza, respiratory viruses. Again, microbiological etiology and associated factors. Alcoholism associated with pneumococci, orum anaerobes, Klebsiella pneumoniae, Acinetobacter, Mycobacterium tuberculosis. COPD and smoking as H. influenza, Pseudomonas aeruginosa, Legionella, S. pneumoniae, Moraxella catarrhalis, Chlamydia pneumoniae. Associated with structural lung disease like bronchiectasis is Pseudomonas aeruginosa, Burkholderia, Staph aureus. Patient with dementia, stroke, decreased level of consciousness is oral anaerobes, gram-negative enteric bacteria. Lung abscess is community-acquired MRSA, oral anaerobes, endemic fungi, M. tuberculosis, atypical mycobacteria. Then associated travel to certain locations of United States is one is Ohio and other is southwestern United States. They are histoplasma hantavirus respectively. Travel to Southeast Asia is Burkholderia avian influenza virus. Hotel stay or cruise ship stay is often associated with Legionella species. If there is local influenza activity, then we have to suspect influenza and also associated bacterial infection of pneumococci and Staph aureus. Bat and bird are often associated with H. capsulatum. Birds have also association of Chlamydia psittaci. Rabbits have Franciella turlininus and sheep have Coxiella burnetii. Clinical manifestations. Patients often have systemic features and respiratory features. Respiratory features include cough, expectoration, pleuritic chest pain, and shortness of breath. Systemic features include fever with chills and other non-respiratory symptoms like headache, nausea, vomiting, abdominal pain, diarrhea, myalgia, arthralgia. On physical examination, the patient is febrile. If hypothermic, it is a poor prognostic sign. On auscultation, crackles may be elicited over the affected area of lung. In 10% of the cases, pleural friction rub can also be elicited. Other physical examination of consolidation includes dullness to percussion, increased tactile vocal fremitus, whispering pectoraloqui, tubular bronchial breath sound. Risk for early deterioration in community-acquired pneumonia include multilobar infiltrates, hypoxemia that is saturation less than 90, acidosis that is pH less than 7.3, mental confusion, severe tachypnea that is respiratory rate more than 30, hypoalbuminemia, neutropenia, thrombocytopenia, hyponatremia, and hypoglycemia. To decide the site of care, we have certain questionnaires. We'll start with curb 65, which is confusion, urea nitrogen more than 7 millimoles per liter, respiratory rate more than 30, low diastolic, low BP, and age more than 65. If the score is 0 to 1, home treatment, 2 requires hospitalization, 3 or more requires ICU admission. Another scoring is smart scope smart cope score, that is S is systolic BP less than 90, multi-lobar chest X-ray involvement, albumin level low less than 3.5, respiratory rate more than 25, tachycardia more than 125, confusion, poor oxygenation and low pH. If the point is 0 to 2, there is a low risk of needing invasive respiratory or vasopressor support. If it is 7 or more, high risk of needing invasive respiratory, ventilatory or vasopressor support. So this is another flow chart. Diagnostic workup for CAP includes chest radiography, repeated if there is no improvement or persistence or worsening of symptoms or physical examination, and also to rule out underlying malignancy. Complete blood count, blood sugar, serum electrolytes, LFT, RFT, blood gases or pulse oximetry, sputum examinations to be sent for gram stain, acid fast stain, culture and sensitivity, direct fluorescent antibody staining for Legionella species. Blood culture for high-risk patient, that is neutropenia secondary to pneumonia, asthenia, complement deficiency disease or severe CAP. In 10 to 20% there is positive blood culture. Urine antigen detection in Legionella for severe CAP and S pneumonia. Biomarkers are serum procalcitonin, that is 1 microgram per liter. PCT may play a role in distinguishing bacterial from viral infection, determining the need of antibacterial therapy or deciding when to discontinue therapy. PCT testing can result in less antibiotic use in CAP with non-concomitant increase in treatment failure or mortality risk. CRP may be of use in identification of worsening of disease or treatment failure. PCR can be done as a diagnostic modality and the sample can be taken from nasopharyngeal swab or sputum, often used in respiratory viral infection including COVID-19 infection. It can also be used for Legionella species, Mycobacteria pneumoniae, C. pneumoniae, and Mycobacteria. CT scan to be performed when there is non-resolving pneumonia and for assessment for complication of CAP like empyema or abscess, lung abscess. Bronchoscopy, thoracoscopy are other modalities that can be performed whenever the indications are present in pneumonia. Now we'll go to the treatment part. Let us go to the outpatient treatment. Previously healthy and no use of antimicrobials within previous 3 months, we can give macrolide or doxycycline. Presence of comorbidities or use of antimicrobial within previous 3 months, we can use respiratory fluoroquinolones like moxi, gamiflox, levoflox, or beta-lactam plus macrolide. In regions with high resistance of macrolide resistance, we can use other alternatives. Respiratory non-ICU treatment, either give a respiratory fluoroquinolone or a beta-lactam plus a macrolide. IPD ICU treatment is beta-lactam, that is ceftriaxone, cefotaxime, ampicillin sulbactam plus azithromycin or a respiratory fluoroquinolone. For penicillin allergic patient, you can give a respiratory fluoroquinolone and aztreonam. Special concern. The Pseudomonas is a concern and anti-pseudomonal, anti-pneumococcal, beta-lactam, that is piperacillin, tazobactam, cefepime, imipenem or meropenem plus ciprofloxacin or levofloxacin, or another is beta-lactam plus aminoglycoside and azithromycin. Other is beta-lactam plus aminoglycoside and an anti-pneumococcal FQ. For penicillin allergic patient, aztreonam. If community acquired MRSA, add Vanga or linezolid. And also the pathogen directed therapy can be attempted for organisms like streptococcus pneumoniae. If it is penicillin non-resistant, penicillin G, amoxicillin, penicillin resistant, we can use cefotaxime, ceftriaxone, fluoroquinolone. H influenza non-beta-lactam is producing amoxicillin, beta-lactam producing second or third generation cephalosporin. Mycoplasma pneumonia, chlamydia pneumonia, macrolide or tetracycline. Legionella species FQ or azithromycin, Chlamydia psittaceae tetracycline, Coxiella burnetii tetracycline, Franciella turulinimus is doxycycline, Yersinia pestis streptomycin or gentamicin, Anthrax, ciprofloxacin, levofloxacin, doxycycline, Enterobacteriaceae is third generation cephalosporin, carbapenem. It is a drug of choice if extended spectrum beta-lactam is produced. Pseudomonas aeruginosa is anti-pseudomonal beta-lactam plus FQ or aminoglycoside. Burkholderia pseudomilleri is carbapenem, ceftazidime. Acinetobacter is carbapenem, Staph aureus. Methicillin sensitive susceptible is anti-staph penicillin. Methicillin resistant vanco or linezolid. Bordetella pertussis is macrolide. Anaerobes is beta-lactam or beta-lactam inhibitors and clindamycin. Influenza virus is oseltamivir. Mycobacterium tuberculosis is anti-tubercular treatment therapy. Coccidiosis species for uncomplicated infection in a normal host. No therapy generally recommended. For therapy, itraconazole or fluconazole may be attempted. Histoplasmosis, itraconazole. Blastomycosis, itraconazole. Now this is the management of COVID-19 and this is as per 17th May 2021. This is the AIMS guidelines. If a COVID-19 patient comes to us, we'll have to classify them into mild, moderate or severe group based on mild disease is upper respiratory tract symptoms with or without fever. There is often without shortness of breath or hypoxia. The patient requires home isolation and care. And the patient is often treated with ivermectin 200 mcg once a day for 3 days and to be avoided in pregnant and lactating women, or hydroxychloroquine 400 bd for 400 bd for 1 day followed by 400 OD for 4 days unless there is contraindication. Inhalational budesonide to be given via meter dose inhaler, that is 800 mcg BD for 5 days to be given or till the symptoms subside. Okay, and then there is also the high risk category of the disease, that is age more than 60, cardiovascular disease, diabetes, chronic lung, kidney and liver disease, cerebrovascular disease and obesity. And then there is the patient with moderate disease, that is anybody with respiratory rate about 20 per minute and breathlessness. The saturation is between 90 and 93. It is between 90 and 93. The patient has to be admitted in the ward and patient has to be given oxygen therapy to be maintained a saturation of 92 to 96, and the device preferred is non-rebreathing face mask. Awake proning to be encouraged. Anti-inflammatory or immunomodulatory therapy using IV methylprednisolone 0.5 to 1 milligram per kilogram in two divided doses for equivalent dose, or equivalent dose of dexamethasone to be used for about 5 to 10 days. Patient may be initiated or switched to oral route if stable or improving. Anticoagulation to be done using low molecular weight heparin, that is enoxaparin 0.5 mg per kg per day sub-Q. Uh, Next is monitoring, clinical monitoring, work of breathing, and there is to be serial X-ray and lab monitoring to be done. In case of severe disease, if the respiratory rate is more than 30 or the saturation is less than 90, admit in ICU. The patient requires NIV. Patient can be attempted with HFNC, or the patient should be given anti-inflammatory therapy, that is steroid, methylpred 1 to 2 milligram per kg, two divided doses, 5 to 10 days. Anticoagulation, low molecular weight heparin, enoxaparin 0.5 mc per dose, sub-Q BDD, and supportive management, and monitor with serial chest X-ray. Other off-label uses, remdesivir to be considered only in patient with moderate to severe disease requiring supplemental oxygen. Tocilizumab also off-label use. All the above criteria are to be met. Other treatment consideration is early initiation of treatment has greater reduction of mortality. Okay. Patients who have severe CAP may benefit from prednisolone and methylprednisolone. NIV may be initiated if there is severe hypoxia and bilateral alveolar infiltrates. And if invasive ventilator to be initiated, the patient to be initiated with low tidal volume ventilation, that is 6 to 8 milligram per kilogram body weight. If the patient is not improving or not responding pneumonia, it is called progressive pneumonia, and the patient, there will be deterioration and development of respiratory failure or hypertension more than 72 hours after initial treatment is often related to intercurrent complication, deterioration in the underlying disease, or development of nosocomial superinfection. Then there are often non-infectious conditions that mimic pneumonia, like pulmonary edema, pulmonary embolism, lung cancer, radiation, and hypersensitive pneumonitis. Other causes for non-resolution of pneumonia include resistance of drug, sequestrated focus, wrong drug, and inadequate dosage of drug, and unsuspected pathogen, and also nosocomial superinfection. In such conditions, CT and bronchoscopy can help us clinch the diagnosis. Complications of pneumonia include respiratory failure, shock, and multi-organ failure. Local complications include metastatic infection, lung abscess, and complicated pleural infection. If the patient is fever and leukocytosis usually resolve 2 to 4 days, and chest radiography abnormality may persist for about 4 to 12 weeks. Prognosis often depend upon the age, comorbidity, site of treatment. The young without comorbidity often recover within 2 weeks. The older and with comorbidity might take longer time to resolve. The prevention of pneumonia can be done by taking various pneumococcal influenza vaccine, COVID-19 vaccine, Tdap, varicella vaccine, H influenza type B vaccine, especially useful in splenic and hematopoietic stem cell transplant patients. Next, let's talk about hospital-acquired pneumonia. And it's often by aerobes and often difficult to diagnose. This occurs because of the patient is in hospital and is often infected with the super pathogens from the hospital, but the patient has better host defenses than patient on ventilator, so often the morbidity and mortality is lower when compared to ventilator associated pneumonia. HAP accounts for about 25% of all ICU infection, and VAP accounts for about 25% of all intubated patients, and HAP increases as the number of days of the stay in hospital increases. And the etiology is common for HAP, VAP, and healthcare associated pneumonia. That is, an aerobic gram-negative bacteria like Pseudomonas, Escherichia coli, Klebsiella pneumoniae, and Acinetobacter. Gram-positive cocci like Staph aureus and oral commensals like Viridans group, coagulous negative staph, Neisseria, and Corynebacterium are also significant in immunocompromised patients. Pathogens is based on the sources of infection, host and treatment related colonizing factor, routes of bacteria entry into the lower respiratory, embolization of the infected biofilm in the endotracheal tube. And there is a scoring called modified clinical pathological infection score with which we can make a diagnosis of VAP. The risk of VAP is highest in the early course of the stay. First 5 days, 3% per day, 5 to 10 days, 2% per day, and more than 10 days, 1% per day. Prevention, the most useful technique is hand washing, and other include avoid intubation if possible, reduce the duration of ventilation, reduce sedation, antibiotic prophylaxis, head and elevation, and always use risk-benefit ratio for transporting the patient outside ICU. Management of hospital-acquired and ventilator-associated pneumonia include piperacillin, tazobactam, cefepime, levofloxacin, and other include meropenem, amikacin, gentamicin, tobramycin, ciprofloxacin, levofloxacin, colistin, and polymyxin. If there is a risk factor for MRSA, you can add linezolid or vancomycin. Thank you for the patient listening.